Good afternoon, everyone. Thank you for joining us today for the Hospice Quality Reporting Program provider training covering the HQRP Understanding the Composite Quality Measure webinar. My name is Rachel Boglai, and I will be your host and moderator today. Our agenda today includes background of the Hospice Quality Reporting Program and quality measurement. What is a composite measure? The Hospice Item Set-Based Composite Measure. Calculation of the HIS Composite Measure. Using reports to monitor composite measure results. And we will conclude today's webinar with a summary, a list of resources, and a question and answer session. Now, I would like to introduce today's speakers. Ms. Cindy Massuda joined CMS in 1999. Since 2015, Ms. Massuda has been the Hospice Quality Reporting Program Coordinator within the Centers for Clinical Standards and Quality. Prior, she worked on Medicare demonstrations with a focus on hospice in CMS's Office of Research, Development, and Information and Centers for Medicare and Medicaid Innovation. Ms. Brenda Karkos is an Associate Nurse Researcher at Apt Associates. She is an RN with many years of clinical and administrative experience in community health, hospice, and oncology. She is certified in hospice and palliative care and currently serves on the Board of Directors for the Hospice and Palliative Care Federation of Massachusetts. Before joining Apt, Brenda was most recently the Director of a hospice program in Massachusetts. Her work at Apt is focused on hospice, oncology, and home health projects. Slide 4 in the slide deck contains a reference list of acronyms that will be used throughout today's presentation. At the conclusion of this program, we would like training participants to be able to 1. Describe HQRP quality measures. 2. Differentiate between an individual measure and a composite measure. 3. Describe the current HIS composite measure. 4. Explain how composite measure scores are calculated using data from individual measures. And 5. Resources for understanding HQRP quality measurement. Now, I will review a few housekeeping items. This webinar is being recorded. It will be posted to the CMS HQRP website, and we will provide you with details on accessing the recording via email when it is available. The phone lines will be on mute for the duration of the presentation. If you need technical assistance during the webinar, please let us know by using the Q&A panel to the right of the presentation. Additionally, you can use the Q&A panel to submit your relevant content-related questions. We will end the webinar today with a Q&A session and will address as many of the questions submitted as time allows. To the right of your screen is an important information panel. This panel contains information with a link to the slides being presented, as well as how to access live closed captioning features in your browser. If you need assistance accessing this feature, please let us know using the Q&A panel. Throughout today's event, we will be using polling questions. The polling questions allow the speakers to gauge your understanding of the material being presented. Each polling question will appear automatically on your screen. Please review the answer choices offered and submit your response by clicking on the circle to the left of the response. You can change your answer at any time before the poll is closed. Your answers are confidential and will only be reported in aggregate percentages. Let's try out the polling function with our first question. You should now see the polling question appear next to the presentation on the webinar screen. The question is, who is considered the founder of the first modern hospice? A. Florence Wall, B. Mother Teresa, C. Dame Cicely Saunders, or D. George Washington. So let's give everyone a couple of moments here to select their response option. The majority of people selected C, Dame Cicely Saunders, which is the correct answer. Before we conclude the event today, we will provide a final wrap-up and a question and answer session. If you have any questions throughout the presentation today, please submit them via the Q&A panel on the right of your screen. It is now my pleasure to turn the session over to our presenters, Ms. Cindy Massuda and Ms. Brenda Karkos.
Thank you very much, and welcome everyone for joining today's webinar. So CMS continues to want to provide these training and education webinars to help with the progressing of the Hospice Quality Reporting Program and to add value to the program by adding different types of measures, including additional composite measures. As you heard, today's webinar is designed to help you better understand the composite measures. The composite measure, and more importantly, how these are different and more robust than the individual measures that comprise them. Next slide, please. I would like to start by briefly reviewing the Hospice Quality Reporting Program, known as the HQRP. The HQRP was established under Section 1814 I-5 of the Social Security Act. At the time, the Social Security Act established the quality reporting requirements for the hospice programs, as well as the provisions that require publicly reporting of the quality measures that relates to the care provided by hospice programs across the country. This slide presents more detail on the evolution of the Hospice Quality Reporting Program. Hospices start data collection using the Hospice Item Set, or the HIS, in July 2014. The HIS data, along with the Consumer Assessment of Healthcare Providers and Systems, or CAHPS data, were used to create the quality measures for hospice. By August 2017, CMS launched the Hospice Compare website to report these quality measures. It's now called Care Compare. By February 2018, Hospice Compare was able to display the original 7 Hospice Item Set measures and the 8 CAHPS measures. The goal is to help consumers compare the performance of hospice providers and assist beneficiaries in making choices for the hospice services that are right for them. In December 2020, Hospice Compare was retired and replaced by Care Compare, and the link to Care Compare is listed here on the slide. Currently, there are only 2 requirements for hospices for the Hospice Quality Reporting Program. This is the data collected and submitted for hospice providers from the Hospice Item Set and the CAHPS Hospice Survey submissions that are the vendors submit on a hospice provider's behalf. Regardless of payer, all Medicare certified hospice providers must comply with these 2 reporting requirements for all patients. In time, for the future of the Hospice Quality Reporting Program, the new Hospice Quality Reporting Program will include administrative measures such as claims-based measures. This is because claims-based data are readily accessible and the use of the data sources minimizes provider burden. For example, CMS was able to eliminate the need for the continued data collection of Section O, visits in the last 3 and 7 days of life, by deciding to rely on claims as the new data source for this information. By collecting this visit data submitted through claims, it means that hospices are now 100% compliant with submission of this information. So integrating HOPE into the Hospice Quality Reporting Program. As you probably have heard, CMS is currently testing a new patient assessment instrument called the Hospice Outcomes and Patient Evaluation, or HOPE. The goal for HOPE is to be more comprehensive than the current hospice item set by capturing patient information as well as patient and family needs. Through HOPE, we will capture information in real time through the hospice day and not just on admission and discharge. When launched, HOPE will incorporate data from the hospice item set, and in time, HOPE will become the one assessment tool for the hospice industry. The Hospice Quality Reporting Program, integrating HOPE and administrative data, which includes claims. Here's a graphic that shows you how CMS plans to integrate HOPE and administrative data, such as claims, into the Hospice Quality Reporting Program. The proposed hospice rule is currently posted for comment, and the comment period closes on June 7th, 2021. Once finalized through rulemaking, the Hospice Quality Reporting Program will eventually include administrative data such as claims, HOPE, which will include the hospice item set, and the CAHPS hospice survey. While we will not be discussing HOPE in more detail today, I do encourage you to visit the CMS Hospice Quality Reporting Program website and look at the HOPE webpage. If you have any questions about HOPE, please email us at hopeassessment@cms.hhs.gov. I will now turn it over to my colleague, Brenda Karkos, who will provide you with some important definitions and with this presentation.
Thank you, Cindy, and welcome everyone. I'd like to start by defining quality measures, or QMs. So QMs are tools that help measure or quantify healthcare processes. These can include the outcomes of care provided, patient perceptions of the care that they received, and the organizational structure or systems that are associated with the ability to provide high-quality health care. The goals for quality measures are to include measures that promote safe and effective care, care that's efficient and patient-centered, as well as equitable and timely. The graphic depicted here shows how a quality measure advises the care or care planning, helps to promote the continuity of care, and can inform quality performance, which can lead back to advising care delivery and making the adjustments that need to be made to improve the care that's provided. So let's go through a few more definitions. A measure. A measure is made up of several components. It should have a title and a description of what it is. It also must have a numerator, a denominator, and some denominator exclusions, or factors that would not be included. You'll hear about different types of measures, and there are two that you'll hear about today. The first is the outcome measure. An outcome measure assesses the results of healthcare experienced by patients. One example of this might be a patient who was free from post-surgical infections, for example, following a knee replacement. Process measures, on the other hand, measure the rate of use of a specific evidence-based processes of care. They usually focus on high-risk, high-volume, problem-prone areas for healthcare. Process measures quantify provider actions such as timeliness of care, care planning, or clinical interventions. One example of this could be the number of patients who receive a visit within 2 days of a referral to a particular service, such as hospice. You can learn more about measures by visiting the CMS website at the link on this slide. So let's look at the current HIS-based quality measures. The data collection for these, as Cindy mentioned, these 7 measures, the original 7 quality measures, began with patient admissions after July 1st, 2014. These include asking patients about treatment preferences and beliefs and values, screening for pain and dyspnea, conducting a pain assessment, and making sure that those who are being treated with an opioid are placed on a bowel regime. These 7 processes were then calculated beginning in April of 2017 for the Hospice and Palliative Care Composite Process Measure, NQF number 3235, which is the last measure listed on this slide. So the CAHPS Hospice Survey is an experience of care survey. It was designed to measure and assess the experiences of patients who died while receiving hospice care and the experience of their family. The survey is another source of information to help consumers when choosing a hospice program. Here is a list of the CAHPS Hospice Survey quality measures that were first displayed on Hospice Compare in 2018. These include the communication with the family, getting timely help, treating the patient with respect, emotional and spiritual support, help for pain and symptoms, training the family to care for the patient, and there are 2 overall measures. The first one is rating this hospice, and then their willingness to recommend this hospice. In the near future, we will have a new measure which is based on Medicare claims data. This is referred to as hospice visits in the last days of life, or HVLDL. This is a respecified claims-based version of the hospice visits when death is imminent pair, HVWDII. Data collection of Section O began in April of 2017, and visit data was used for this measure. As of earlier this year, hospices no longer need to collect the HIS data from Section O that was originally associated with these two visit measures. Once approved through rulemaking, CMS will rely solely on existing data for the calculation of this measure. That'll be the Medicare claims data. And using the Medicare claims data minimizes provider burden by removing the need for data collection through clinician assessment. These quality measures are reported on CareCompare. CareCompare is a streamlined redesign of the original 8 CMS Healthcare Compare tools, which included Hospice Compare. Like the original Hospice Compare tool, consumers can select and compare multiple hospice providers, up to 3 at a time, and view their quality measure information. CMS publicly reports these quality measures so that consumers can compare providers in their service area and use this information to assist them in selecting a hospice that's right for them. A link to CareCompare is listed on this slide. CMS currently uses the HIS and CAHPS hospice survey data to calculate a hospice's performance on QMs, and in time will add administrative data or claims. Hospice programs can review their data before it's made public, and we'll talk about these reports later in the presentation. Hospice QMs currently include only process measures, but will in time include outcome measures as well as other measures. Hospices with fewer than 20 patients will not have their quality measure scores publicly displayed because a score with such a small denominator may not be reliable. And these hospices will see a footnote that says the number of patient stays doesn't meet the required minimum amount for public reporting for this reporting period. CareCompare also includes additional data about hospices, such as the types of conditions they serve, the locations where the hospice provides care, such as home, assisted livings, or skilled nursing facilities, and the average daily census. So here's a shot of CareCompare and what the site looks like. If you've not visited the site, I would really encourage you to check it out and to compare a few hospices in your own area. You can choose the provider type, then choose the location that you're searching for by state, name of the town, or the zip code, and then click search. And a list of hospices in that area will come up for you to compare. Let's go on to a polling question. So here's a polling question for you. How do publicly reported QMs help consumers? Is it A, find out who's currently on hospice? B, locate the names of the hospice nurses? C, help consumers compare providers in their service area and assist them in selecting a hospice? Or is it D, A, B, and C are correct? And the answer is C, helping consumers to compare providers in their service area and assist them in selecting a hospice. So now let's move on to talking about composite measures. What is a composite measure? First, I'll go over a definition for you. A composite measure is a measure that contains 2 or more individual measures resulting in a single score. Composite measures can include a combination of any number of individual quality measures, just 2 or 3, or many. These can include 1 or more process measures and or 1 or more outcome measures, and ideally these should reflect some common underlying construct such as the quality of hospice care. So let's go through some of the components of the measure that we mentioned. We mentioned these earlier, but here are some definitions. The numerator. This is the measure focus and describes the target process, the condition, or the event, or perhaps an outcome expected for the targeted population, such as those who might be free of infection after a surgical procedure, for example. The denominator defines the population being measured It could be the whole population or just a subset, like it may only be patients who had a knee replacement by a particular surgeon, for example. The denominator exclusion, this identifies members who should be removed from the measure population, and hence the denominator before determining if the numerator criteria were met. Now I'd like to take some time to look at a basic example of a composite measure that you all are probably familiar with. We're going to look at an example of a GPA as a composite measure. So first, we have 4 students that are in the same track, and each one is taking the same 5 classes. In order for them to continue to receive their financial aid, they have to meet the following criteria. Each has to maintain a grade of a C or better in all classes, and they have to all complete all 5 classes for the semester. So this table just shows the grade point average scale, and it shows that A would be equal to a 4.0 and F would be a 0. And so since students have to receive a C or better, they would have to be above a 2.0. And this table shows the individual classes and each student's grades for that semester. From this table, you can see that Amy, Michael, and Stella maintained a C or better in all 5 classes. Kate withdrew from her Research 101 class, so she receives no grade for that class. And on this next table, the scores have been converted into the grade points, and there's a total score for each student, with Amy being the highest and Stella being the lowest. And even though Kate withdrew from her class, you can see her total score is actually higher than Stella's. Now let's look at how we're going to calculate the GPA. So the numerator is the total sum, the individual scores in which the student meets the criteria for the individual grade, obtains a C or better, and the denominator is the number of classes completed for each student. So here you can see that 3 students met the criteria. They completed all 5 classes, had a final grade of a C or better, and 1 student, although she had a high GPA, she did not meet the criteria of completing all 5 classes. So let's just look at the comparisons. So let's assume the quality measure was the same as the criteria for continuing with financial aid. So here is the semester GPA for the 3 students who met the quality measure criteria. And you can see that 1 student was excluded. She did not meet the inclusion criteria as Kate withdrew from that research class. So she didn't meet the 5 class criteria to be included in the measure. So the students who qualified for financial aid, so these grades represent individual measures. This GPA is a simple average-based composite measure of individual measures. The GPA captures the semester grades for students into one single score, and only 3 of the 4 students met the criteria to qualify for ongoing financial aid. Now let's look in more detail at our current composite measure based on the items that are in the hospice item set. So this is the Comprehensive Assessment at Admission, NQF number 3235, also called the Hospice and Palliative Care Composite Process Measure, Comprehensive Assessment at Admission. This process measure was finalized by CMS in fiscal year 2017 final rule. All patient admissions that occurred on or after April 1st, 2017 are included in the measure calculation. Like each of the 5 classes in our GPA example, this measure uses the 7 individual HIS process measures as its individual components. This composite for the Hospice Comprehensive Assessment Measure was first publicly reported on Hospice Compare in the fall of 2018. So the Comprehensive Assessment at Admission measure assesses the percentage of hospice patients who received care processes consistent with the guidelines. It's calculated using data from the existing HIS admission items and those individual measures that we talked about earlier. The measure reports the percentage of hospice patients who received all 7 HIS care processes for which they're eligible at admission to hospice. This is like our GPA example where the students had to complete all 5 classes. This is considered an all or none composite measure. So this table just shows you a different view of the 7 measures that were referred to earlier, and these 7 items relate to the preferences, health conditions, and medication section. And here's how the measure looks on Care Compare. And you'll see a description of the measure, patients who got an assessment of all 7 HIS quality measures at the beginning of hospice care to meet the requirements. Higher percentages are better, and you'll see the national average is 88.7%. So there is Hospice A at only 56.7%. You can see that Hospice A is not doing as well with this as Hospices B or C. Now let's look at how this measure is calculated to create what becomes the composite. So here are those individual measures again, the 7 measures. So there are a few factors that can impact the calculation that you should be aware of. The first is that some patients may not qualify for what they refer to as conditional measures, and those are the NQF 1637, pain assessment, and the NQF 1638, dyspnea treatment. And what this means is that if screening indicates that the patient has no dyspnea, then the patient will not be eligible for any dyspnea treatment, obviously. And perhaps the patient has no pain, no active pain, and no pain issues at all, then the patient would not need to have a complete assessment for pain, and that item would be skipped. These patients are still eligible for the numerator as if the hospices completed the care process for these conditional measures. So that is, the hospice would be given credit for completing the comprehensive respiratory assessment or the comprehensive pain assessment. So let's just look at the numerator for this particular measure. And this includes all patient stays from the denominator who meet the individual component quality measures applicable to the patient. And the denominator is all patient stays except those with exclusions. The numerator is divided by the denominator to get a percentage. If the denominator was 10, for example, and you only had 8 patients that met the numerator, that would give you 0.8 or 80% for a score. So now let's look at some exclusions. Denominator exclusions for this measure are if there is a discharge HIS, but that stay is missing a matching admission record, then these would be excluded. Also excluded are any active patients at the time of the calculation, so patients that were still living and were still on hospice. Hospice patients under 18 years of age are excluded from this measure as well, and there is no risk adjustment or stratification. So I'd like to review one simple case example so you can see how this is calculated and demonstrate this with some small numbers. So let's say Hospice C has 7 patients. For most of the patients, all 7 care processes were completed. However, one patient was not asked about treatment preferences or beliefs and values. Another patient was not assessed for pain after screening positive. Therefore, only 5 of the 7 patients triggered the hospice comprehensive assessment measure. So here's a table that shows the 7 measures in light blue, and in red at the bottom you can see the composite measure results. So we'll go through this table in detail so you can see how this is calculated. So first of all, you can see that the denominator for the first 3 measures listed here are all 7. Since one patient was missed when asking about treatment preferences or beliefs, only 6 of the 7 triggered those first 2 measures, the treatment, preferences, and beliefs and values. So the hospice's observed percent for those 2 measures is 85%. On the third row, you can see that all the patients were screened for pain. So the observed percent is 100%. For pain assessment, the denominator is 6. And that's because if the patient was screened for pain and didn't have pain, or pain was not an active problem, they would not require the assessment. So we're only starting with 6 patients in that category. However, we did hear that one of those patients who did screen positive did not have a pain assessment. So only 5 of those patients met the measure, and the score is 83%. For the last 3 measures in light blue, you can see the dyspnea screening, dyspnea treatment, and patients treated with an opioid. You can see the denominator matches the numerator, and this means that they were all eligible and received the care process, so that resulted in a 100% score for those 3 measures. Now the last row in red is not a tally of these rows above at all. It just shows you how the hospice fared in the composite measure. You can see that the denominator is still 7. We know that 2 of the patients did not have all the 7 care processes completed. So this really dropped their score when you look at just the composite. And even though the individual measures are high and can be quite a bit higher, you can see what a difference it makes with the composite measure if they did not meet all of the 7 care processes, since this is an all or none measure. So let's see on the next slide how this hospice compares with the other 2 hospices or 2 other hospices. Okay, so here you see hospice A, B, and C. While each one looks like they have pretty good scores, you can see the difference in the composite measure, where hospice C is quite a bit lower than the other 2 for completing all 7 care processes on admission to hospice. Of course, we used a very low number of patients as well, so that would also make a difference. But missing those care processes definitely makes a difference in the composite measure. Okay, so what is the value to the consumer for this measure? The NQF number 3235 measure provides consumers and providers with a single measure regarding the overall quality and completeness of a comprehensive assessment at admission. It's a measure that can be used to meaningfully and easily compare quality across hospice providers. And it's a measure that sets a higher standard of care for hospices than the 7 individual HIS measures, and better reflects what the hospice conditions of participation, or the COPs, expect. So why don't we pause now for a polling question. So what does the comprehensive assessment at admission measure? Is it the percentage of hospice patients who were admitted to the hospice with dementia? Care processes including screening for pain, dyspnea, and asking about treatment preferences? Or C, whether the social worker and chaplain visited the patient within the first 5 days after a hospice admission? Okay, so the correct answer is B, care processes including screening for pain, dyspnea, and asking about treatment preferences. Okay, so let's summarize the information that we've covered thus far on the composite measures. Composite measures can address several areas or quality indicators simultaneously. Unlike a single concept measure, composite measures combine several concepts or indicators into one single score. And although each individual measure will still have its own numerator, denominator, and resulting score, just like our individual classes in the GPA example, the criteria for the composite will determine whether the individual score will actually be included in the final composite calculation. The composite score can be a percentage, as in the comprehensive assessment at admission, or it can be a single number, as in the GPA score. And as with both of these, a single score is more readily understood and easy to compare. So this is just to show you that the HQRP QM User's Manual is really a great resource for you for these HIS quality measures, as well as some of the other quality measures that will be coming down the pike. Consult the manual for more details and definitions. The link is included on this slide. And in a short time, this manual will be updated, so there'll be a new manual being posted soon on the current measures page. Now let's spend some time talking about reports and how you can use these to track your hospice's performance on this composite measure. There are many valuable reports available to hospices, and you can use these reports to interpret your quality measure results, investigate issues, issues, and assist you with your QAHPE or your performance improvement programs. You can access these reports by selecting the CAHPS reporting link on the CMS Key System for Providers webpage. The hospice-specific reports that we're going to review are located on the Hospice Quality Reporting Program report category. And you can learn more about these and other reports by reviewing the CAHPS Reporting User's Guide for Hospice Providers. The link is located on this slide. Chapter 3 of the guide outlines all of the reports available in the Hospice Provider Report category. And this is a graphic that just shows how prior to public reporting on Care Compare, you can use these confidential reports, such as the quality measure reports or the provider preview reports, to see how your hospice is doing. To monitor your compliance, you'll want to look at the final validation reports with all of your submissions, and then check the hospice timeliness compliance threshold reports. So here's an overview of the differences in these reports, and this is a great slide if you wanted to print this out and keep it handy, because the reports, it can get confusing on which reports do what. In the left-hand column, you're going to see the CAHPS QM reports, the review and correct reports, and the HIS provider reports. And the second column tells you whether these will or will not include a full year of data. So for CAHPS QM reports, you can see an asterisk, and that tells you that you will not see a full year unless you actually request it. So it can be provider requested, but you can request to see a full year. The third and fourth columns tell you whether these are for patient stay level data or hospice level data. And you can see that the hospice provider preview reports only give you hospice level data, but the others give you both, patient level and hospice level data. Column 5 tells you the report is affected by data correction deadlines. And for QM reports, this is no. And the second to the last column tells you whether the underlying data can be changed. And you can see that this can be done with the quality measure reports. When you run these, if you see something that needs to be corrected, this can be done. And for the review and correct report, this is possible as well. However, you'll see a double asterisk, and it says that the data correction period is open. If it is open, provider corrections to the HIS records will then appear in a future release of the review and correct reports. But if the data period has already closed, provider corrections to HIS records will not appear in any future release. And the very last column tells you whether these can be run on demand. The HIS provider preview report cannot be run on demand. Okay, so this slide summarizes some of the important facts about the HQRP QM report category. So these are user-requested, on-demand CAHPS reports. They'll give you confidential feedback on your agency's performance. You can run these for any reporting period of your choice, and they can include a full year of data if you request. They include both patient level and the hospice level data, so you can look at individual patients and who triggered some of your quality measures, as well as how your hospice is doing overall. And they provide confidential feedback on your performance. And there's data was calculated on date that shows you when the most recent calculation occurred, so you can tell when that report was compiled. Because these display the national average scores, you can use these for benchmarking and for comparisons. So let's look at the hospice level quality measure report. And this report shows you the measure ID. It'll give you the numerator, denominator, the hospice observed percent, the comparison group national average for the same time period, and then the comparison group national percentile for each of the measures. And this is just a screenshot of the HQRP report category and how you choose this report, Hospice Level Quality Measure Report. And here's what the report looks like. And you can see each measure is listed in the column on the left. It's got the measure ID, the numerator, the denominator for this hospice, and the hospice's observed percent, as well as the national average and the group national percentile. So let's just look at one line. Look at the pain screening line, which is the fourth row down. And this report shows that 241 was the numerator out of a possible 256. So the hospice's observed percent was 94.1%. So a little lower than the national average, which shows at 97.9%. So most hospices do very well with pain screening at 97.9%. Okay, so here is the hospice patient stay level quality measure report. And this identifies each patient whose qualifying HIS record was included in the QM calculations for the selected report period. It includes the per patient and per measure information, such as whether the patient stay triggered the measure, whether the patient stay did not trigger the measure, or whether the patient stay was excluded from the denominator. And here's a screenshot of the report category, and you would choose the patient stay level quality measure report. And here's a sample of this report. This is a screenshot. This report indicates the status per measure per patient during the requested report period. So if it shows a B, the measure was not triggered. So you can see the patient did not pass the measure, and it displays the B in bold so it's easy to identify. An E means the patient was excluded from the measure. We talked earlier about measure exclusions. If you see an X, that means the patient triggered the measure or passed the measure. And a C would display in the admission date column next to the date if the admission date was extracted from the discharge record. So if an admission record, for example, was missing for some reason, there would be a C next to the date for the admission date. And you'd have to do some research to find out why that admission record was missing. NA would display in the discharge date column if it indicates the discharge date is not available, and that might be that the patient stay is active, the patient's still alive, or the discharge record could be missing. So the quality measure count is the last column on the report, and this provides a quick view of how many measures were triggered or passed during each patient's stay. So this is just a quick review of the review and correct reports. So this report contains hospice level quality measure data for a full 12 months, 4 quarters, contains associated patient stay level data. It also includes all HIS-based measures. Providers have access to QM data prior to the data correction deadline for public reporting. This report gives providers an opportunity to ensure the accuracy of their data and allows providers to track quarterly data cumulatively. There have been previous trainings on review and correct reports, so we encourage you to visit the CMS HQRP website on the Training and Education Library page for more specific trainings if you want some information and a good training for your staff on review and correct reports. So let's move on to some polling questions. So which reports are included in the HQRP folder in the CAHPS system? Is it the review and correct report, the hospice patient stay level quality measure report, or C, the hospice level quality measure report, or D, all of the above? So the answer here is D, all of the above. Okay. So which QM report will tell providers which patient stay triggered or did not trigger the measure? Is it the review and correct report, the hospice patient stay level quality measure report, or C, the hospice level quality measure report? Or is it D, all of the above? And most of you answered B. The answer is B, the Hospice Patient Stay Level Quality Measure Report. And this is the one that will give you some information on who triggered or did not trigger the measure. So this is a great way to investigate if your numbers are off and you're trying to figure out what the problem is. Okay, next slide. So this graphic gives you a snapshot of the provider preview reports. And these are system-generated reports, as opposed to others that we mentioned that were user-generated that you can actually run for yourself at any time. They cover HIS data from specific time points, and they're issued at specific times for a 30-day preview period. And both the Hospice Provider Preview Report and the CAHPS Hospice Survey Provider Preview Report are available in CASPR. These two separate reports are located in your CASPR folder, and you're encouraged to use these to review your quality measure results before they're posted on CareCompare. So hospices have 30 days to preview results, and if a hospice believes their data are inaccurate, they can request a CMS review. Review requests must be made during the 30-day preview period. And there are links on the slide here to the two locations where you would go to put in a request. You can find this information on the CMS HQRP website. These web pages are located on the sidebar and are also included on this slide. So you're probably all aware by now, but this is just a quick review of the exemptions that were due to the COVID-19 public health emergency. CMS temporarily exempted providers from the submission of the CAHPS Hospice Survey and HIS assessment and discharge data for Q1 and Q2 of 2020. Following the November refresh, November 2020, the data was frozen. CMS will not issue provider reports for those refreshes that continue to display this constant or frozen data. The CareCompare site data will go back to its expected quarters of data to be displayed in May of 2022 for HIS and May of 2023 for CAHPS. For more information, you can view the COVID-19 public reporting tip sheet at this link, and it's also located in the resource section in the slides. And you can also look on the CMS HQRP website on the public reporting key dates for providers webpage for information about what's being displayed in the reports. This is just a screenshot of the folder that contains the provider preview reports for both the HIS and the CAHPS. Okay, and here's a screenshot of the provider preview report. And then a screenshot of the CAHPS Hospice Provider Preview Report. So another polling question for you, how many days do providers have to preview their quality measure results once the preview reports are released? Is it A, 60 days, B, 30 days, C, unlimited, or D, 90 days? It looks like most of you answered. Correct answer is B, 30 days. So it's important to be watching for those preview reports, and if you do have an issue, to make sure that you put in a request within those 30 days. So we're almost done. I just want to summarize and go through some of the resources that are contained in these slides. So at this point, you should be able to describe the Hospice Quality Reporting Program quality measures. You should be able to differentiate between an individual measure and a composite measure, describe the current HIS composite measure, and explain how composite measure scores are calculated using data from individual measures. And you should, after looking at the resources, be able to list 2 helpful resources for understanding Hospice Quality Reporting Program measurement. And we'll review those quickly right now. So on this page, some of the important web pages are on the CMS HQRP website, and that's the main page, the HIS web page, the current measure web page that we talked about, and the HQRP Training and Education Library. Here are two manuals that you should consider bookmarking for easy access and reference. So the first is the HIS Manual version 3.0, and then the HQRP User's Manual. The current version is listed here for the user manual, but it is being updated, as I mentioned, and you'll find the user's manual on the current measures webpage. And lastly, these two important sites for CAHPS, the CMS CAHPS Hospice Survey webpage and the official CAHPS Hospice Survey website. So these two resources are on the Comprehensive Assessment Measure. The fact sheet is quite detailed and will give you a lot more information if you still have questions and are trying to figure out how you're doing on the composite. I think it's a really useful tool for you to consider printing out. And if you have questions about quality measure development, you can find some good resources here. We've also included the KEYS Technical Support Office training page and the CASPR Hospice Reporting User's Guide on this slide as well. And for more information on how to access the HIS and CAHPS provider preview reports, go to the CMS HQRP website and look in the download section of the following pages. And this is a slide that's also helpful as a resource to print out of the different help desks. And this ends the presentation. I'm going to turn it back over to Rachel, who's going to lead us through some questions that have come in.
Thank you so much, Brenda. Let's go ahead and start looking at the questions that have come in. Our first one is, our comprehensive pain scores are low on Care Compare. We seem to be doing everything that is required for the HIS, and we cannot understand why our scores are still low. Cindy, can you take this one?
Sure. So the CASPR QM Patient Stay Level Report will give you information about which patients triggered the 7 individual measures versus which patients triggered the Hospice Comprehensive Assessment Measure. As we mentioned earlier, this is an all or none measure, meaning that the measure reports the percentage of hospice patients who received all 7 HIS care processes for which they are eligible at admission to a hospice. One of the best resources for more information about this measure is the printable fact sheet entitled Hospice Comprehensive Assessment Quality Measure Background and Methodologies Fact Sheet. It can be found on the current measures page of the CMS HQRP website, and it's noted in the resource section of this presentation slide deck. And I just want to add that all the Q&As will be available with links following at sometime after this presentation today for you to be able to access. Thank you.
Thank you, Cindy. Our next question here is for Brenda. The question is, our pain scores have a number 5 by the scores which say results are based on a shorter time period than required. What does this mean?
Yes, Rachel. So those numbers are the footnotes that are just informational. They don't negatively impact your hospice scores. So footnote number 5, results are based on a shorter time period than required, means that the results were based upon less than 12 months of data. The information with more detail about footnotes is located in the last few pages of the Hospice Data Dictionary, and that can be found in the data catalog on the Care Compare website. And a link to Hospice Data Dictionary will be included in the Q&A document that Cindy mentioned when it's posted after this webinar.
Thank you, Brenda. This next question is also for you. It states, what does it mean when there is a footnote that says the number of patient stays doesn't meet the required minimum amount for public reporting for this reporting period?
Sure, Rachel. So this is footnote number 1, And this indicates that these scores are not available because your hospice had too few patients that met the denominator criteria to report the measures. So less than 20 patient stays in a reporting period. As we mentioned in the presentation, hospices must have a minimum of 20 patient stays in the denominator of each measure to have the data appear on Hospice Compare. And this is to ensure that scores presented on the site are fair and reliable and are a good indication of hospice quality. So publicly displaying quality measure scores on the basis of small samples can potentially give users misleading information about the quality of care. Therefore, CMS has set a minimum sample size of 20 qualifying stays. Hospices with small sample sizes will have their scores suppressed from public display.
Thank you, Brenda. Our next question states, can you tell me why all of our patients do not show up on the provider preview reports? Cindy?
Sure. So the HIS provider preview reports include only those patients discharged in the reporting period in the denominator. For example, if a patient was admitted to hospice during the reporting period but discharged outside of that reporting period, they would not be included in the measure calculation for that period. However, if a patient was admitted outside the reporting period but discharged within that period, they would be included in the measure calculations.
Thank you. Our next question. We have a question about the Hospice Comprehensive Assessment HIS measure. We do not understand why we sometimes have many patients with a B not triggered under this measure. Can you please help clarify? Brenda, can you take this one, please?
Yes, so we did talk about that when we talked about the reports. So to be included in the denominator of the Hospice Comprehensive Assessment Measure, patients must meet all the criteria for the measure. So if you see a B on the patient stay level report for your hospice, it means the patient did not meet the criteria and it did not meet the numerator criteria for the measure. They met the denominator rather, but not the numerator. The hospice will not get credit for the measure for this patient. For example, a patient will not trigger the Hospice Comprehensive Assessment Measure, footnote B, if the hospice did not complete one or more of the 7 care processes needed to trigger the measure, as in the example that we talked about during the presentation. This could be a missing pain screening or perhaps not asking the patient about the treatment preferences or beliefs and values. As noted earlier, the CAHPS QM Patient Stay Level Report does provide you the information about which patients triggered the 7 individual measures and which patients trigger the Hospice Comprehensive Assessment Measure. Details and specifications for the data that's included in each of the various quality measures can be found in the HQRP Quality Measure User's Manual version 3.0, and you can find this manual in the download section of the HQRP Current Measures page. And as I mentioned, a revised version of the current manual will be posted soon.
Thank you. Let's see, our next question here. Why is there such a delay in the public reporting of our QM scores? Cindy, can you please take this one?
Sure. So there is a delay because the quality measure scores are calculated based on 12 rolling months of data. And we have to do that to ensure reliability and validity of the data in order to publicly report the data. So appreciate the question. Thank you.
Okay, the next question here. We understand from the proposed rule that there is a measure called HCI on the horizon. What does CMS plan to begin reporting on such a measure?
So the
Cindy?
Hospice Care Index, which is the the Hospice Care Index, thank you, which is the HCI, is a claims-based measure that's currently being proposed. And if it's finalized, we'll begin to report this measure, as we state in the fiscal year 2022 hospice rule, no sooner than May 2022. And so since we're during the comment period and so forth, and we're in rulemaking, I recommend that people look to the rule to appreciate the details about that measure. And we also have resources on our announcement and spotlight page on our CMS HQRP website. It includes our HCI video, is also on our website. Thank you.
Thank you, Cindy. So next question here. In our hospice, we have the nurses doing a full comprehensive pain assessment, even if pain is not an active problem, as we feel it is a good way to fully evaluate if the patient has pain. Do we get credit for those on the comprehensive pain assessment measure? Brenda?
Sure. So HIS doesn't replace a thorough and ongoing assessment of each patient as required by the hospice COPs. And it doesn't replace a standard, clinical practice or good clinical judgment. The HIS is a standardized set of items intended to capture patient-level data on each hospice admission, and these items are used to create and calculate the quality measures. So according to the measure specifications, if documentation in the patient's clinical record indicates that pain is not an active problem for the patient, the nurse would select 0 and answer no to J0905, which is the active problem item. For the purposes of completing the HIS, they would then skip the comprehensive pain assessment. However, patients are included in the measure if the patient was screened for pain within 2 days of the admission date and they reported that they had no pain. Thank you for the question.
Thanks, Brenda. This next one is for you as well. You mentioned the different reports that hospice can use. Which one is the most important to make sure that we are on track for success?
Well, actually, all of those available reports will help you stay on track. However, the quality measure reports are not affected by the data correction deadlines and can be run on demand for the time frame of your choosing. So as we mentioned in the presentation, the hospice level quality measure report will give you the numerator, denominator, your hospice's observed %, and the national average for the time period. And then that hospice patient stay level report will identify the records that were included in the quality measure calculations for that report period that you select. And that'll include which patient stays triggered the measure, did not trigger the measure, and who was excluded. Both the review correct and the provider preview reports are affected by the data correction deadlines. The provider preview reports allow hospice providers to review their measure quality results and their facility level CAHPS survey results. However, you cannot change the underlying data at that time. So again, it's important to really start at the beginning and be looking at your data as it's been submitted and be checking your quality measure reports that you can run on demand at any time.
Awesome, thank you for that. This next question is for Cindy. Cindy, can you review again the difference between an outcome measure and a process measure?
Sure. So a process measure is a measure that evaluates the rate of use for a specific care process, such as whether a pain screening or discussion about patient preferences occurred. Process measures tend to focus on high risk, high volume, or problem-prone areas in healthcare. One example of this is patients who got a timely and thorough pain assessment when pain was identified as a problem. Then an outcome measure, on the other hand, that measures the results of healthcare that was provided or experienced by the patient. An example of an outcome measure would be a patient found to be in severe pain and had their pain brought under control within 2 days.
Thank you. So our next one, we have noticed that since September 2020, we are not seeing the provider preview reports to look at our QM results for the composite measure. Why is this?
I'll take that question. So due to the COVID-19 public health emergency, there was a temporary exemption to the Hospice Quality Reporting Program data submission requirements to respond to the public health emergency. and the public reporting of hospice's data was frozen after the November 2020 refresh. So following that refresh, the data publicly reported has been held constant and will be that way through November 2021 refresh. So while this data is being held constant, there's no provider preview reports will be issued for those refreshes since we continue to display the constant or frozen data. And you can find additional information about this COVID-19 public health emergency data exemption in the Hospice COVID-19 public reporting tip sheet, which is in the download sections of the Hospice requirements and best practices webpage. Appreciate the question.
Thanks, Cindy. This next one here is for Brenda. Brenda, our hospice overall percent for assessment of all 7 HIS quality measures is 77.4%. But then if I look at the percent for each of the 7 measures, our scores are all way above 77.4%. Can you please explain this?
Sure. The Hospice Comprehensive Assessment Measure, as we mentioned, is an all or none measure. So the composite measure captures whether all of those 7 care processes are conducted for each patient, but also considers the circumstances in which patients were not eligible for one of the conditional process measures and you should still receive credit for those toward the measure calculation. For example, if a patient screened negative for pain, they are not eligible for the individual component pain assessment measure. However, in the composite measure, that patient would be counted toward the numerator for the composite measure. The numerator for the composite measure would include patients who screened positive for pain and received a comprehensive pain assessment, but also patients who screened negative for pain and did not qualify. Your CASPER QM patient stay level reports, as we discussed, will give you that detail on the patients that triggered the 7 individual measures versus which patients triggered the comprehensive measure, and that should help you drill down to where your issue is. But as you saw from our example, even if you have high scores on the 7, if you're missing those 7
Okay, so it looks like we have time for one final question today. This final question is for Cindy back on the HCI measure. So for this new HCI measure, will hospices be able to see their data prior to any public reporting?
Because of the rulemaking, I'm going to defer people to look at the proposed rule, and to locate. We do have discussed it in detail in that rule about how you would be able to access information for the claims-based measure, the Hospice Care Index. But I'm going to refer people to the proposed rule for that. So thank you very much.
Thank you, Cindy. That concludes our event. I'd like to thank our presenters for sharing their knowledge on today's webinar. This concludes the Hospice Quality Reporting Program Provider Training covering the HQRP Understanding the Composite Quality Measure webinar. The webinar slides presented today, which include the answers to the polling questions, as well as a recording of the webinar, will be posted to the HQRP website. Once posted, we will send an email notifying you where to download the materials. Thank you all so much for attending. Please enjoy the rest of your day.